Dr. Natarajan is the Director of Preventive Cardiology and the Paul and Phyllis Fireman Endowed Chair in Vascular Medicine at MGH. He's also an Associate Professor of Medicine at Harvard Medical School. Dr. Natarajan received his MD at UCSF and completed residency at the Brigham, and subsequently completed cardiology fellowship at MGH, at which time he also received a master's in biomedical informatics. He established his lab in 2017, where he and his team study naturally occurring germline as well as acquired human genetic variation to advance the prevention of cardiovascular disease. He leads several consortia to use genetic epidemiology, large-scale sequencing studies, genotype-driven human investigation, and genetic testing implementation. Among his scientific contributions, he has pioneered human knockout discovery and investigation to prioritize therapeutic targets, monogenic and polygenic characterization of heritable traits through whole genome sequencing, and the novel concept of somatic mutations contributing to cardiovascular disease. He has authored over 200 papers and has been cited over 20,000 times. Please join me in welcoming Dr. Natarajan.
Great. Thanks. It is so exciting to be with you guys and be with you guys in person. And good to see lots of friends and people, at least familiar faces also from Twitter too. So focus of my research is to use genetics to understand mechanisms of cardiovascular disease, but a natural opportunity is also in risk prediction. That'll be the focus of this talk. It's actually a major reason why I'm here at UCLA. There's a big NIH meeting that UCLA was hosting on the use of these tools and the advancement of these tools. And we'll talk about some of that, and then also some unpublished data. As a preventive cardiologist, it's an exciting tool just because much of our clinical work is centered on risk prediction. And how we predict risk has basically been about the same for the last 50 years. So we'll talk about these new exciting opportunities. Many of you may know, I'm originally from Los Angeles. There was a summer in college. I went to college at Berkeley, but I would always come home for the summers. And one summer I did a part of an AHA program, did research with John Tobis in the cath lab. The first time I had worked with a physician doing research. So certainly foundational for me in my understanding of what was possible. And that was all in the old hospital across the way. And I know that I still know that hospital. I have like a really good mental map, basically going there every day for a summer. And so all of this, even though this has been around for a long time, feels very different and very new. So let me see if I can. There we go.
Some that worked in that hospital for 20 years still got lost. So.
Yeah, no, I walked back over there right before this, and it just looked so familiar, so awesome. All right, and so some of the stuff that I'll talk about was sort of summarized in this recent scientific statement from the AHA, and these are generally not guidelines. These are kind of again, as the state of the science, and then highlight opportunities for future research, really. So much of this notion of using genetics to understand risk and to prioritize what to do comes in these notions of precision medicine. The concept of precision medicine, as stated here, the prevention and treatment strategies that take individual variability into account. This notion is not a new notion in medicine, certainly not a new notion in cardiovascular medicine, but the term has been popularized since 2015. In 2015, some of you may know, President Obama, in his State of the Union address at that time, announced the Precision Medicine Initiative and used this term. And what has changed compared to what we are doing is that the ability to capture inter-individual variation has substantially advanced. The technologies that are at play, through consumer wearables, but also through molecular assays, which can at reasonable cost be applied at scale. So lots of interest in understanding how to use these tools to allocate medicines to provide effective, safe therapies. And what is unique about genetics is that much of this is permeating into the public space outside of the traditional clinical care. And so there are many unique opportunities to intersect with clinical care that are quite distinct from what we do today. I mean, even for, we have long recognized the role of lipids in cardiovascular disease, but your patient can't just go out and get lipids, but they can get their, whole genome sequence. And they can get increasingly so risk scores that purport prediction for these clinical outcomes. And this is old by a few years, but you can see, millions of Americans have participated, many of you have participated as well. And so beyond, that's better. So beyond direct-to-consumer streams, there is, substantial efforts in broadly genetically profiling, largely funded by NIH and others. So lots of patients of ours participate in these studies. And increasingly so, these are much more directly connected with clinical care. This is just a representation of some of the key biobanks that have spun up really over the last 5 to 10 years. Most of those in the US really over the last 5 years that are continuing to increase in size. These are the numbers, not only recruited, but the numbers who are sequenced as well too. So it provides really unique opportunities, not only for discovery and mechanism, which we primarily focus on, but now trying to see, what are the clinical opportunities. So the notion of using genetics to, prioritize risk or to understand risk is not a new concept. This is, one particular example of trying to understand the drivers of risk. This is a very traditional, but not necessarily as traditional at the time, a case control study of taking individuals with early onset MI. These were patients who were hospitalized in the Boston area hospitals. This is a unique collaboration at that time between the Brigham and Mass General Hospital. And this was a, kind of a unique case series because it was increasingly recognized in the early 20th century that individuals were now starting to get MIs more commonly at young age. At that time, it was other cardiovascular disease consequences that they would get. There were, substantial alarming epidemiological rates for cardiovascular disease in the early 20th century into the mid 20th century. And a key anecdote that flagged all the public health concerns was when President Eisenhower in office had an MI. Paul W. White, who is the founder of our unit at MGH, was an external consultant. This is a picture of him with Dr. Eisenhower. And this really sort of fueled the overall public need for addressing these concerns. And so many of the professional societies came together saying that, we need to do something about this, particularly for premature atherosclerotic cardiovascular disease. And that became sort of the impetus for many of the for the guidelines as we know them today, really starting from the 1980s, really early 1990s. So as you can see, what we have been doing has largely been the same over the last about 40 years. And the trends have definitely improved, certainly good that it's not coming up like this. Cardiovascular disease still has the dubious distinction of still being the #1 cause of death in the US. Cancer is a very close second. You see the rates going up really over the last decade. And importantly, so actually in the world over the last 2 decades, cardiovascular disease has overtaken communicable disease as the leading cause of death in adults. The problem also with stagnation of basically doing the same thing is that as the population gets larger, as the population gets older, the costs attributable to cardiovascular disease continue to rise. So, what we have focused on have been seminal traditional cardiovascular disease risk factors that have come from many of the early epidemiological cohorts. This one is a classic figure from the Framingham Heart Study that coalesced on a small number of cardiovascular disease risk factors. And an abundance of evidence since then have all linked them as causal risk factors and really aligned with the traditional notions of precision medicine. So if somebody has diabetes and you treat the diabetes, you will improve their prognosis associated with diabetes. If they're a smoker, you treat the smoke, or you tell them to stop smoking, and hopefully they do, and that addresses the risk associated with smoking. For most of the individuals in the population don't yet have cardiovascular disease, and so this notion of tabulating the number of risk factors ultimately synthesized in scores have been in place since the early 1990s, since the original Framingham risk score, but really with the same inputs. The challenge is there is a sweet spot for its performance among individuals of middle age, right? So you have reasonable discrimination across individual risk factors as they increase, that they can cross a clinically well appreciated threshold for elevated risk, and then you can recommend some therapy. The challenge is at the extremes. For older adults, they're always estimated to be high risk since most of the events are happening later in life. And all the individuals who are younger will always be estimated at low risk. So there is a need to identify the individuals earlier in life who are at future risk for cardiovascular disease. Much of the genetics today for atherosclerotic cardiovascular disease focuses on lipid disorders, namely familial hypercholesterolemia. We won't go through the foundational work, but the seminal work by Brown and Goldstein in the 60s and 70s, ultimately culminating a Nobel Prize in the 1980s, provided an important foundation for cholesterol and its role in cardiovascular disease. And this was sort of in parallel with the epidemiological observation analyses in Framingham and these other cohorts in the 1970s, but really using molecular genetics and exceptional individuals to hone in on this as a particular causal feature, before we had randomized controlled trials of statins and others. But it's been, very controversial about genetic testing for FH, even though these tests have been around, because the causal factor is LDL cholesterol, which you'll treat anyway, and which advances in genetics have really over the last 10 years have helped us understand potential clinical opportunities for these niche cases. In case-controlled data sets, we've seen that individuals for given bins of LDL cholesterol, those who have monogenic etiologies for having high cholesterol, have substantially elevated risk compared to individuals who got there without a monogenic etiology. Much of this is now along this hypothesis of just like pack years for smoking is also LDL years, so the amount that you have LDL elevated, and for the time frame as well. For monogenic factors, obviously, these are operational early in life. And so here, much of this is really focusing on the duration aspects. And this is a very similar study that was done in Europe. We recently did another study in the Million Veterans Program in multi-ethnic samples, really showing the same. This is more of a prospective study. The prior analyses were exome sequencing. This is at least tabulating the most commonly observed mutations that are observed in the US. And similarly, we find prospectively, looking at incident cardiovascular disease risk, individuals who have FH mutations have worse prognosis, and the prognosis persists even when you account for the LDL cholesterol. FH is relatively common among monogenic conditions. It's about 1 in 250 individuals, 1 in 300 individuals. That's about the same prevalence as type 1 diabetes and celiac disease. I'll go through some of this, and I'm really providing a framework on how we think about the polygenic risk aspects. Now, today it would be, unethical to do a randomized controlled trial of statin versus placebo among individuals with FH. But if you look at older studies and older clinical cohorts where there is some heterogeneity on how people are prescribed statins, and you look in those observational data, the people who benefit the most from statins are the individuals that have FH mutations. And this is interesting because if you look at all statin randomized controlled trial data, regardless of the subgroup, the relative risk reduction is the same. So if you're a diabetic, if you're a smoker, you have hypertension, the relative risk is the same. What drives the benefit is that you overall have high risk. So the absolute risk increases. And so even though the relative risk reduction is the same, the absolute risk reduction magnifies. And so the number needed to treat shrinks. Here, this suggests that not only do you have elevated risk because you have FH, the relative risk reduction is even greater. So the absolute risk reduction further magnified, number needed to treat is much smaller. So there really isn't a consensus statement or a guideline on FH genetic testing. Probably the closest to it is an expert panel that Jack convened that basically says, there's a lot of text here. If you think about it, you should test it. But what really has changed, again, over the last 5 years is that now beyond statins, we have many more expensive medicines. So the first guidelines that incorporated these medicines were in 2018, and there is like the word cost all over the guidelines. If you look at the prior one, 2013, cost is used once, basically saying that statins are cost effective. And so the guideline authors spent a lot of time in thinking about those medicines, which were, the prices have come down, but were particularly pricey at the time. How do we get them to the right patients, but also being cost conscious at the population at large? And so much of the focus in those guidelines really were in the primary prevention population, really aligning with the FDA label, which is among patients with FH if they don't have atherosclerotic cardiovascular disease. There has been some liberalization over time, especially as there are more medicines, the costs come down. This is not technically a guideline, but the ACC recently had a consensus on non-statins, suggesting that everybody with severe hypercholesterolemia should have, much lower LDL cholesterol. But if you had FH, maybe we should be a little bit more aggressive. And this is kind of, obviously, these things are moving target along with the evidence. So, FH is, very helpful for us to understand mechanism, represents a niche case where you want to be very aggressive in allocating LDL cholesterol lowering medicines. But most of the premature events are not happening in patients with FH. And you have many patients coming in with premature MIs, and they often don't have severe hypercholesterolemia. So a lot of, again, I'm featuring Framingham as a cohort that I know well, but a lot of other cohorts have done similar analyses that if you look at what the familial contribution of risk is, there is a sense, at least in earlier studies, that when events happen in first-degree relatives early, your risk increases. And your risk increases independent of the other cardiovascular disease risk factors, include LDL cholesterol. You don't have a significant increase if it's non-premature risk. And so these observations and others really supported the notion that there may be other genetic players that, especially because this is common in the population, there may be common genetic variation that plays a role. And so really since 2007, the first genome-wide association study for age-related macular degeneration, then very soon after for coronary artery disease, there have been a number of regions of the genome that are associated with LDL cholesterol. This is a little bit outdated because there's a couple new, much larger papers that were published just last year that we led. But as you can see, now there are about 300 unique regions of the genome that are associated with coronary artery disease. Each of the alleles that are primarily indicating risks are common. Common is in about 5 to 40% of the population, not like 1 in 300 like FH. FH has a risk of about threefold for cardiovascular disease. Each of these have about a 5% increased risk for cardiovascular disease. Okay, and a number of them do map to well-established risk factors, meaning in addition to being associated with coronary artery disease, they also modestly perturb risk factors as well too. But the vast majority, as in about 60% of them, are not also associated with other traditional cardiovascular disease risk factors. And it's a lot of work to try to unpack why they're associated with coronary artery disease. However, as I was alluding to in the beginning, kind of regardless of understanding mechanism, one can use the totality of that data to try to predict risk. Each of these risk factors are fairly common. Each of these modestly increase risk, but one could, in theory and empirically shown, that if you capture all of that information together, you can create what is now termed a polygenic risk score. The training data inherently is basically the population-based discovery data. So simplistically, in the genome-wide association study, we have cases and controls, and we're looking for alleles that are significantly enriched in controls. Each of those will carry a weight, basically how much more enriched is it in cases versus controls, and then you can create a weighted score. There have been a lot of advances in how to use that data. The initial iterations, now about 12 years ago, really focused on just taking the significant alleles, which at the time, 10 years ago, was about 11. Now you could take 300. Next iterations are then weighting by how much enrichment it is in cases versus controls. And now there's one thing that we appreciate is that as we do larger and larger genome-wide association studies, we find more and more regions associated, and they're obviously in our full list of alleles that have been assessed. They just don't meet statistical significance. So one can actually use the totality of the data without necessarily doing larger and larger genome-wide association studies and actually build better scores. One thing that's pretty interesting is that these polygenic risk scores, they predict risk, but they predict risk independent of self-reported family history for cardiovascular disease. And what does that mean? One, self-reported cardiovascular disease is pretty crude. Patients don't always necessarily know the mechanisms of heart disease in the family, but family history also captures a lot of non-genetic features. And when we talk about heritability, strict definition is a trait that it's transmitted from parent to offspring. Right? And so in the mechanism of that, in the conventional notion, it's thought of by DNA sequence variation, but it doesn't have to. People eat similar things, especially, if a parent has a certain income, the child is most likely to have ultimately that adult income. So there are many different features that influence familial enrichment for coronary artery disease. Genetics is just one part of it. Now, when you look in the population, the information of a genetic risk score provides additional information beyond these traditional risk factors. This is if we were to use it in screening across everybody. This is actually in the first release of the UK Biobank. Many of you guys may have heard now has been 500,000 individuals ascertained from the general population in the UK. And in the first release, about 150,000 individuals. That's what this group focused on. A traditional metric for clinical utility is the C index, which is basically the likelihood, if you're going to say that somebody has a case, that you're identifying a case. If your score is saying that it's not a case, how likely are you identify that as a non-case? This is the performance of each of the traditional cardiovascular disease risk factors. Individually, a genetic risk score, is on par, if not maybe a little bit more information. All the risk factors together, and then you provide some more information beyond that. Okay, so we were interested in saying, that's in the UK, and that's a population-based cohort. What about in the context of what's happening in the US, various different academic medical centers, where we think we have amazing clinicians, and maybe we're figuring this out because we're pretty good at allocating statins and identifying risk. So this is in 3 different geographically distinct cohorts, actually pretty ancestrally distinct. So this is our an earlier iteration of our biobank in New England across Mass General Brigham, which is about 85% of European ancestry. The Penn Medicine Biobank, part of University of Pennsylvania, about 40% African ancestry, and then the Mount Sinai Biobank, which is about 60% Hispanic American ancestry. It's pretty surprising that it performed pretty similarly across each of these cohorts, meaning kind of despite all the things that we do today, despite all the risk factors, there's an enrichment for a high polygenic risk score for the individuals who have coronary artery disease. And it's pretty similar across each of these. This is when using this as a continuous score, so per standard deviation. Now, if you look at individuals who have, a high polygenic risk score, individuals who have familial hypercholesterolemia, obviously individuals with FH have high LDL cholesterol. If you have a high polygenic risk score, the LDL cholesterol is really not that elevated. There's modest elevations. And then if you look at the tool that we use to identify risk, the pooled cohort equations, the distribution of the scores are basically the same if you have a high polygenic risk score or not. And this legacy of using the top 20th percentile is kind of similar to most other additional risk factors, something that confers about a 2-fold excess risk. Now, we did this really in motivation and started this study when the last cholesterol guidelines came out in 2018. And this is when they advanced this term of risk enhancing factors that was actually not there before. This was before, as you guys may not know, in 2013, it was basically you had high risk, 7.5 or 10%, that was high risk at that time. Everybody was eligible for a statin. We should all recommend a statin. In 2018, same. Everybody above 7.5% is eligible for a statin, but we should be using additional features, clinical features, what the patient's preferences are, and then use that to kind of help identify whether somebody is suitable for a statin. What was common among each of these additional risk factors is that they all increase risk by about 2-fold. And so that was basically the rationale by saying, okay, we have this biomarker, it increases risk by about 2-fold. But we also wanted to understand the practical implications. This is the advantage of using a biobank, because we can see exactly how people are being managed. And among that group, that middle category of 7.5 to 20%, where there is some clinical equipoise, there's about 4% of individuals, actually in totality, about 4% of individuals who would fall in this middle category, the high genetic risk, not already on a statin. So not blowing up clinical practice, but identifies a use case that really harmonizes with current guidelines. And importantly, when we think about guidelines, I think all of us are very used to randomized controlled trial data. But if you look at what drives primary prevention guidelines, it is largely epidemiological data, because it's really hard to do randomized controlled trials in primary prevention. They're very expensive. You need lots of individuals because they don't accrue that many event rates. And you have to follow them for a long period of time. So the pooled cohort equations, that has not undergone a randomized controlled trial data. Each of those individual risk factors, epidemiological association, and then doing a risk factor, and then developing a risk score. Same with these risk enhancing factors as well. So really this adheres to the evidence base. But an important concern, appropriately so, is that these risk scores do perform differently across each ancestry. Also important to recognize that most biomarkers in medicine don't perform exactly the same across all groups, including by ancestry and self-reported race and ethnicity. The tension and the problem with things like polygenic risk scores is that the training data is largely Eurocentric, because much of the initial investment went into like the Framinghams and others, which are largely European in ancestry because they're very well phenotyped. You don't have to re-recruit another cohort. So all the initial investment went into those. And so the genetic association data for coronary artery disease and our understanding of the genetic architecture for coronary artery disease is primarily enriched for Europeans. And that's why scores kind of for anything always perform better in Europeans compared to non-Europeans. And that's not because that there is more genetic predisposition to these, at least not necessarily in Europeans compared to non-Europeans. Also, also important to take a step back and just look at how much genetic variation there is across people. So across any one individual and in the population, we're about 99.5% similar as far as genetics. Okay, so genetics plays an important role in general in the population for human disease. So if you look at like mice and humans, mice don't get atherosclerosis. You have to make an atherogenic mouse. So the template for the human is important into developing atherosclerosis. What we're looking at here is population-based variation to say, among humans, the variation, the naturally occurring variation that we see, might that be informative? That represents a small number for the amount of variation between two different individuals. There's lots of variation that's observed because there is rare variation and common variation. It's an important concept because I think like there is a lot of challenges in the history of genetics, because a lot of this is also rooted in eugenics, especially for the initial people who did a lot of work in genetics research. And so I think once we start to disentangle things like self-reported race, ethnicity, and concepts of genetic ancestry, which are rooted in where people are from, I think we just have to take a step back and say, actually, people are all pretty similar, and we're looking at a narrow search space in its role in trait risk. Importantly, that does play an important role in risk prediction. So the NIH and others have invested actually a lot of resources in trying to improve the representation of these cohorts for a variety of reasons, including for risk prediction. But we know that we learn a lot, based on differences in population history, that we can have unique insights for mechanisms of disease when we look at genetically distinct populations. And so in 2015, when President Obama launched the Precision Medicine Initiative, that sort of came together as what is now called the All of Us research program. That's the Framingham for our generation, or for the new century. This is a largely decentralized cohort, but there are many different health centers, including ours, which recruit into the All of Us research program, and lots of efforts to recruit individuals of non-European ancestry. We recently, in the recent release, about 300,000 individuals compared to the US Census to say, okay, how good is All of Us doing? And so if you compare it to the US Census, it's pretty similar, so pretty representative, at least by percentage of Europeans in the US. Overrepresented for individuals of African ancestry, but the others are actually underrepresented. So stark underrepresentation by absolute numbers for Hispanic or Latino, and then also in Asian Americans as well. So really motivated by this and just thinking about what are effective strategies to get non-European individuals or non-European ancestry individuals engaged in research, is that I think a lot of this needs to be grassroots and from the community. So we actually have developed this. We were launching it later this year, basically using kind of all of us infrastructure, but really collecting data that we think are important for South Asians, and have developed basically a new framework. And we're very excited about this. So that, the reason why I'm here, this is one such consortia, is to say, okay, we need to invest a lot of resources in, genetically profiling all these different populations, especially if we're going to be using these tools in healthcare, and then also opportunities for mechanistic discovery. But as it's been clear, is that methods can help with some of this, improvement in methods to try to improve the portability of these scores and overall performance of these scores. One such approach that we've taken is leveraging a lot of newer methods that we and others have developed in developing multi-ancestry polygenic risk scores. And interesting, also leveraging genetic information from genetically correlated traits. An interesting observation over the last few years has been, if you take a genetic risk score for a risk factor like LDL cholesterol and predict cardiovascular disease, just like FH variants, you gain additional information from the alleles. So you have an independent signal from the alleles themselves beyond just a cross-sectional LDL cholesterol measure, because you're getting a lot of that longitudinal data. And that's also true, interestingly, for blood pressure and for diabetes. So we can take that information and train new scores based on pleiotropy, and then other actually clinical outcomes in cardiovascular disease, and develop a new score. So this is kind of like the evolution of at least coronary artery disease polygenic risk scores. So this just kind of represents the general range of variance of risk that is explained by a polygenic risk score across percentile of the score, and then prevalence of coronary artery disease is kind of one of the first. We get more gradation of risk as the years go on. Much of this is an increase in the number of individuals that go into the training data. This was a paper led by Amit in our group. This was when we'll come back to this paper, but an important advance was beyond the legacy polygenic risk scores. We explained much more of the variation, but individuals who were up here were actually at markedly higher risk, and gave a framework, again, that was comparable to monogenic risk. And the new score, when we have more training data for coronary artery disease, but now we are also including training data that is related to coronary artery disease, and we can identify a lot of very high-risk individuals. So in that prior score, we found a good number of individuals who are at threefold risk. That is, again, largely similar for most monogenic traits for the threefold risk. But in the prior score, it's about 8% of individuals. That's, for FH, it's like 0.05%, where you can identify a threefold risk. But now we're claiming that it's about 20% or 22% of the individuals you can use genetics and find actually very high-risk individuals. What's pretty neat is that the improvement also is there across each of the different ancestries. Before we had very poor performance in individuals of African ancestry. It's still not great, but much better. And performance across all the other groups are actually starting to approach what it is in Europeans. Okay, now what if you give this what if you give this scores back? And this is from a study that was done at Mayo actually a number of years ago, in earlier iterations of scores, and they did very prescient. They did a randomized control trial. They said among individuals who are at intermediate risk, you randomize to giving them just their clinical risk factor information, but here clinical risk factor information plus the genetics. And they see a genetic counselor, they see their cardiologist. What happens? Individuals who got a genetic risk score were more likely to be put on a statin, but that seemed to be restricted to the subset that had high genetic risk. Say, okay, are they going to be more, are they going to benefit more? So now we have the luxury of luxury relative to FH data. Now we have completed randomized controlled trial data for statins. And a number of those legacy studies were consented for genetics, and there's DNA available. So we did broad genetic profiling and then calculated polygenic risk scores, and like a pretty conventional subgroup analysis to say, people at high genetic risk, are they likely to benefit from statins? What was surprising, and actually not what we anticipated, is that individuals who had high genetic risk had a greater relative risk reduction from statins. Again, very different from other clinical risk factors. So this is, basically for individuals who don't have high genetic risk, but similar to when you look at most statin trials, is about a 20 to 25% relative risk reduction for about a 40 milligram per deciliter lowering in LDL cholesterol, but here about 46% lowering for people with high genetic risk. Very similar to the retrospective data actually for FH, but striking as far as, really these notions of precision medicine. We're not just enriching for events, we're enriching likelihood from benefiting from that specific therapy. So that absolute risk reduction is further magnified and the number needed to treat is further shrunk down. So even though we're thinking about these things as, at least in this context in middle age as risk enhancers, this actually is unique in that it identifies likelihood of benefit from a therapy, which in the end is what we want to get at. And you could say, okay, is this a fluke? Is this just related to statins? And since that notion has been replicated for other therapies, these are for the two PCSK9 inhibitor therapies. So something in the notion for cholesterol. Could be other therapies, but we're just starting to get data for those potential therapies. So, we hope that these kinds of risk scores will kind of now start to move beyond legacy risk prediction, predicting events, and then just kind of give the same therapy to everybody, but really trying to hone in on kind of the pharmacogenomics aspects, or at least the aspects of precision medicine, likelihood to benefit from a therapy. This is one such simulation, just saying, if you happen to know this information related to cholesterol and you designed a clinical trial using this data, actually you can have a much more efficient clinical trial. Now, as we talked about in the beginning, the clinical trials for coronary artery disease are largely in secondary prevention. And those previous studies are also in secondary prevention. So could there be a role in secondary prevention? Again, all of this I've presented to you have been in primary prevention. And I guess what would the role be in secondary prevention? Because we're pretty aggressive. You guys are all very aggressive, I'm sure, for patients who had coronary artery disease. Again, in the 2018 guidelines, and now increasingly so, we have more and more therapies, largely right now in cholesterol, that can continue to drive down LDL cholesterol, but cost is still a real practical concern. And where exactly should you go for the LDL cholesterol? Now ACC/AHA moved to less than 70. In Europe, it's less than 55. In some scenarios, less than 40. That could be pretty costly, there's out-of-pocket costs and costs to the insurer. And so when people, we should think about really identifying individuals who we should drive down their LDL cholesterol, but also when people design clinical trials, they're to make it more efficient. They want individuals over a reasonable period of time to accrue a reasonable number of events. So identifying individuals who are more likely to have recurrent events is really helpful. So we did this analysis where we looked at individuals who had prevalent coronary artery disease, likelihood for developing events. And quite interestingly, the top predictor for recurrent events was a polygenic risk score. And, hindsight is 2020, and maybe this makes sense because we're pretty good at dealing with modifiable risk factors. So in a population of individuals where you are basically constraining to the same goals, normal LDL cholesterol or low LDL cholesterol, normal blood pressure, fixing the diabetes, preventing smoking, all of those start to not become important predictors for future cardiovascular disease event in that population. So other factors that are not addressed, like the genetics, actually start to rise to the top. And so for new clinical trial designed for coronary artery disease, whether it's related to cholesterol or not, this could be an important factor in enriching for events. And there are, I think, opportunities in novel clinical trial design, like adaptive clinical trials, where you have, a number of features that you profile individuals at baseline. You conduct the trial going forward, and based on their response, is usually a pre-specified analysis. Then you can start to hone in on the group where you're more likely to benefit. Now, most of the work on risk has focused on middle age because most cardiovascular disease cohorts are ascertained at middle age. Because again, just like it's expensive to run a clinical trial, it's expensive to maintain a cardiovascular cohort. And if you're writing a grant, you need to have over a reasonable time horizon, some returnable. And so starting a cohort at like birth for coronary artery disease is tricky through traditional funding mechanisms. And so the scores for PCE, the pool cohort equations and predictors really focus and are optimized in that middle group. But the genetics, which are, unique among these, is that information is theoretically obtainable at conception. But its use can, in theory, be used early in life, really before the onset of many of these traditional cardiovascular disease risk factors. And I go back to the initial motivation for the contemporary clinical guidelines for cardiovascular, or motivation for the guidelines, is really focusing on individuals now getting cardiovascular disease early in life. And where we have moved towards is really preventing events among individuals, identifying in middle age and then preventing the events later on. We're really not doing much for individuals who have premature events. What we do, and has been the same, again, for about 30 years, is screening lipids for adults in their 20s, identifying individuals who have very abnormal LDL cholesterol, and then starting statins. And, that has been in place for a long time. We as a field, and medicine as a field, is actually really not good at identifying those individuals and managing those individuals. But most of the events are not happening for individuals who have severe hypercholesterolemia. So that should be in place, but we need to do more. And so, as I highlighted that initial paper, a tantalizing aspect is that there is a mode of risk that you can identify for young individuals that harmonizes with greater risk, just like severe hypercholesterolemia. That obviously is uncommon, and this group is, in the top 5th percentile, so 1 in 20, so about tenfold, more than tenfold enrichment. And actually, if you look at, really across the range of middle age, some 40 and beyond, most of the events for people who are starting in a cohort in their 40s and having events over the 10-year horizon, most of the events are really identifiable by a genetic risk score and are not identifiable by our current clinical risk factors. So these, patients who had events are all obviously undertreated because they're not being identified. The information from the genetics decays over time. Over time, the importance of the risk factors overtakes, appropriately so, the role of genetics. So individuals who have a high genetic risk score definitely do have premature subclinical coronary atherosclerosis, but they're not overwhelmingly identified as such. But importantly, the role for identifying early individuals who are at risk early in life is that when you start cholesterol lowering early in life, the effects compound over time. This is a really nice paper right here, just basically looking over the time horizon of statin versus placebo clinical trials. And you look at the hazard ratio by year across the clinical trial. And it's not a proportional hazards. It's not like the same hazard ratio from year to year to year. The longer you're on the statin, even over a 5-year period, the more benefit that you have. And this is extrapolating that line out to genetics. And this is a recent paper we had from 2 days ago, basically along that notion, showing that if you had genetic perturbation, so basically at birth, your LDL cholesterol was lower, the amount that you lower that LDL cholesterol substantially magnifies the risk reduction over life. So again, importance for identifying risk early in life, because you can really make a big difference intervening early in life. Now, what happens if you start to give this information back in a larger setting, and where the prospect isn't necessarily just genetics or just statins? Like, how would people respond? Now, there haven't been too many studies. This is probably the best. This is about 6,000 individual single arm in Finland, returning both a clinical score and also their genetic risk score. And this was, important. Lots of the people felt like, even though the genetic information is static, they felt like it was actionable for them for non-statin reasons, that they would, modify their risk, like lifestyle modification. There's a large number of individuals. And if you looked at as a predictor, what is the effect of having a high risk? Individuals who have high risk are more likely to change their lifestyles for the better. And that was independent for clinical risk and for genetic risk. It's kind of like among the best studies right now, aligned with that notion that genetics may help with lifestyle modification. And what we hope to get to, and again, it's really hard to do these, there is, one such study where individuals were ascertained early in life, so called the Cardiology study, that has been followed now for at least 3 decades. And we find that among these individuals, some have subclinical atherosclerosis, most don't, that individuals who have high genetic risk across a lifetime can really identify high risk. We have started using this in the clinic largely in the context of research studies. Commercially available tests have largely not been available up until basically this past year. This is with one such company that was supposed to have it commercially available, but then there's Color Genomics, and they basically have become one of the major testers for COVID and use their genomic technology for basically for PCR testing. So they plan to come back to this in 2023, but then there's some other companies that have come out to market. These are largely patients that are coming out of our preventive cardiology clinic. There's an enrichment in that clinic for high polygenic risk score. And in tabulation, how we use that information, you can kind of see much of that information was used for medication allocation from some lifestyle modification. Now, we have developed a framework for multiple polygenic risk scores to be used clinically. This is kind of a collaboration with our health system and then also the VA through a VA-funded grant to deliver polygenic risk scores in the VA. But we'll be pivoting that machinery also within our health system as well, too. So this is all still relatively early days, but really kind of exciting, coming back to the initial motivations for why we're doing these things in preventive opportunity and addressing important clinical needs. So to wrap up, the genetics here is not esoteric, as in it's already out there with our patients. It is slowly coming back to clinicians, often via our patients. But from a healthcare standpoint, from an insurer standpoint, it is information that really only needs to be obtained once. And that sort of static piece of information can get revised. We can use it to calculate a genetic risk score for anything. Importantly, we and others actually doing a lot of work in the portability of polygenic risk scores, and some of this also in the near term is just how you report this information as well too. There is an evidence base that actually supports its use clinically, that it's aligned with the evidence base that is supporting other non-traditional risk factors, really for middle-aged adults. We think that there could be a role in secondary prevention. That's actually a notion that is fairly early. That data was unpublished data, but I think an exciting new avenue and may help with clinical trial design. But I think a real opportunity is going to be for younger patients. We're basically undertreating all the younger individuals who have, and later in life will develop cardiovascular disease. But, engaging those people in their health is really hard to do. They're not thinking about what's going to be happening decades down the road. So we need tools like this and others, and also trying to understand how you better engage such individuals. And in the end, it's, a number of you guys are preventive cardiologists, you're all cardiologists. What is unique in preventive cardiology is that much of the visit is sort of trying to capture risk that is related to the patient, communicating that risk, but ultimately communicating likelihood of benefit of a strategy that we hope to pursue. And so that is where we're hoping kind of all risk factors will go towards, but our efforts have really been focused on genetics. So a lot of people, obviously, that go into the work that come along this way. These are the people in the lab, and we often have talented remote people like Ashley, who's a UCLA medical resident. So I think at this point, I'll stop and open it up for questions.
Covered a lot of ground. So I have a couple of questions.
Yeah.
I'll ask maybe one or two. So, there's definitely no question that traditional risk factors miss on our residual risk for many people. And clearly, you look at this, like this is going to be much more, kind of information. But the reality for a lot of patients that we're kind of seeing, at least here in some medical center, you're looking at more than that these days. So HSCRP specifically and calcium scores. So is there evidence, like the bottom line is if the calcium score is 0, is there, at least for the middle-age cohort, for the younger cohort, it may be more interesting, probably not finding that yet. But for the middle-age cohort, are you still adding probably more incremental information?
I think so I'll just repeat the question because a lot of people are virtual. So today in 2023, in addition to the traditional cardiovascular disease risk factors, we use a lot of additional things. So there's the risk enhancing factors and also subclinical atherosclerosis like CAC. And a powerful tool has been imaging, including at least delaying potential initiation of therapy with a coronary artery calcium score of 0. I think important one is that evidence based is also not on a clinical trial. It's again based on epidemiology. And so far, imaging has been the best predictor. Basically, if you have disease, you're more likely to have events. For calcified atherosclerosis, that's happening often in middle age. Everybody starts out at a calcium score of 0. So that's why I think real opportunity, the real meat of the benefit is going to be for individuals earlier in life. That's why when we scoped out the middle age part, it really have binned it among the risk enhancing factors where it's among the things like CRPV, among the things that increase and upclassify risk. I don't think it'll be the end all. I do think there's something to be said for likelihood of benefit. And this seems to be among those features unique in being more likely to predict benefit from a statin compared to others. And that notion is just kind of hard to put in, I think, in guidelines necessarily. And if you have that as a distinguishing feature, maybe that needs to undergo a randomized controlled trial data. I don't know anyone who's going to do that. In the UK, they're talking about potentially running a clinical trial based on that. So I think for many of the patients that we see today, particularly in cardiology, they're usually seeing us later, often in middle age. In preventive cardiology, sometimes we have the luxury of seeing these patients early, but it's usually the familial risk that gets them in. But I think it's going to be more early in life before we have this. Interestingly, for CAC, again, there aren't that many cohorts that have been followed long enough to look at this in middle age. We have started to do a lot of work with CTA data and have some unpublished work in revision that among patients who have a CAC of 0, if they have a high polygenic risk score, they're more likely to have non-calcified plaque. Now, what does that mean? What is the absolute risk estimate, and over what time horizon we don't know? But among those individuals, maybe we should be doing other tests. Maybe it's not a non-contrast CT, maybe CTA. That's early days. So a lot of it is, it doesn't necessarily have to be an either or. It's just what is the right framework that makes sense. So it's a great question.
That was fantastic. I'm very grateful to interventional cardiologist here. I'm going to ask a provocative question. I actually read the paper that came out a couple of days ago. On that, of a 38-year-old brown man with a reasonable LDL, let's say 70.
That's pretty good for a South Asian man. Yeah.
72,
Maxed out on life. All right, got it.
No, this is lifestyle. There's more and more data coming out, like you published, that it's not just, lower is better and duration of lower is better, right? And I think SEC retweeted some stuff about how like each point of LDL you drop is another incremental reduction in events. So I come to your clinic, right, with some knowledge about this, and I say, please give me a statin or prescribe a statin. What's your response going to be?
Oh, this is great. Okay. I posted this poll on Twitter, by the way, about a year last year. So no, this is good. So the question is, Rishi was asking for somebody who comes in who is not in middle age, but maybe close to middle age, South Asian male, technically 40. I crossed that threshold very recently, so it's okay. Has a pretty optimal LDL cholesterol. And asks for a statin, what do you do? Just given the totality of data and unrelated to polygenic risk scores. So one, if people ask for a statin and there aren't absolute risk contraindications, my threshold for saying yes is pretty low. There's really no reason to deny if somebody comes, if it's like a teenager, I'm not sure what I would say. Nobody is opposed to that, but somebody in their 30s, very reasonable. And the reason being, one, LDL cholesterol is very important in its role for cardiovascular disease. But if you look at the distribution of LDL cholesterol and what the optimal LDL cholesterol is, it's tough to understand, but the data suggests that in the population, the mean LDL cholesterol is much higher than probably what it should be. People continue to make cholesterol-lowering medicines because as you continue to add on, you continue to lower cardiovascular disease risk. It's not like blood pressure. You can have blood pressure that's too low and there'll be more problems. Okay, and it still continues to be a monotonic relationship. If you look at contemporary hunter-gatherer populations, non-human primates, other non-primate mammals, their LDL cholesterols are about 40 to 50. We don't generally see that for adults, even people who are maxed out on lifestyle. And I think a lot of it is just like how we live our lives today, the calories that are available to us, the occupations that we have today compared to our ancestors like 10,000 years ago. There's been, a trivial amount of human evolution over that time. And so, our lives are certainly much better, but we're dealing with some other physiological consequences. So I think a very appropriate view of saying, okay, who cares about allocating risk? Like everybody should be on some form of cholesterol lowering medicine or another. And I think there is some good rationale for that. Actually achieving that is really hard. Most people don't want to take a statin. Most people don't want to be on medicines, right? Even though there is this monotonic relationship for people who generally have low absolute risk, if you stratify risk, their events later in life will still be low. You can still bring it down, but the number needed to treat will start to magnify a lot. So really hard to take that as a population-based strategy. But if people are motivated and who are low risk and who understand that, sure, why not? And, they kind of understand that as well. So I still do think there is a role for stratifying risk because that can also help with guidelines and really push things. And then, patients will kind of agree. If we as a field just say everybody needs to be on a statin, that probably will work against us, I think. But yeah, I think identifying the right people early in life is going to be key. That will be an efficient strategy.
Those are great thoughts, Pradeep. I have a more hypothetical question, the initial slides, you showed all these loci and probable genes connected, and it's a lot to unpack. While the polygenic risk score is obviously a very useful statistical tool, but you sort of project this and come up with, some kind of a thought or platform of how this information can be used to devise new therapies.
Yeah, so we are taking a mishmash of a variety of different pathways, all leading to coronary artery disease. Based on that, you would not hypothesize that these individuals, or I would not hypothesize that these individuals would benefit more from cholesterol-lowering medicines. So one, this could translate to other therapies, maybe not. But when people are designing, in general, most of these trials, ideally you're identifying biomarkers that may predict benefit, and usually it's a biomarker that is tied to the pathway that you're perturbing. So if it's cholesterol, you would not get a bunch of people who have an LDL cholesterol of 20, so at least enrichment for that. But generally, they're also enriching for often at least one other risk factors so that people will get events over a reasonable period of time. This could be among those features because it's among the risk modes that are not yet currently captured. So I think at least efficiency for clinical trials. I have no idea whether it's going to ultimately lead to, like, you can do a pre-specified subgroup analysis. And a lot of pharma companies are thinking about this just for the purposes of enriching for events. The ones who are interested in lipid modulating therapies are interested in pre-specified secondary analyses. The reason to do, pre-specified as opposed to these, exploratory analyses is that there's a little bit more statistical rigor. Often you can't necessarily just go to the FDA with that information, but if it passes that muster, that really helps support now doing a prospective randomized controlled trial. But, one could conceivably parse out different pathways that influence coronary artery disease. Once you slice and dice this, it becomes less good as far as a predictor for coronary artery disease. But we are trying, we have this grant and have ascertained a bunch of clinical trial data to say, can we use, again, just like we borrowed additional information to improve a coronary artery disease score, what if we borrow information about the polygenic architecture of LDL cholesterol? Maybe the two of them together will be even better at predicting for individuals who lower cholesterol. So, Eric.
Pretty fantastic. And I'm also going to ask also a selfish bias question with my line of noticing in terms of AHA guidelines and all the data, like the big question to me is also what about, I'm not talking about necessarily like a chip, That's
Yeah, yeah.
another whole exciting field that could be such a huge authority and, you know, the polygenic risk scores that discuss sort of these other risk factors. You know, it's interesting because we're looking at some of the, I guess, to my knowledge, the non-biologic sort of epidemiologic studies of things like the ERIC, you know, the community trials where in one major study you can see that there are higher risks or higher associations of seen in the independent traditional cardiovascular risk factors. Right. Do the biobanks have the nuance or the ability to also look at this history of malignancy? I mean, is this something that is being looked at? It's possible. And also talking about how there's been a lot of discussion as well of CT imaging and data. You know, there's no probably better population to have that amount of data than the cancer population.
Yeah.
I was wondering if you could comment on that as well.
Yeah, no, great question. Eric is highlighting key subgroups that are known to have increased cardiovascular disease risk, namely patients who have had prior cancers, chemotherapies, and a lot of, you know, current work on stratifying the risk for those individuals. Can a polygenic risk score, at least in its current form, help? And that hasn't been well looked at. It can. I mean, this is the nice thing about biobanks. You know, if you look at the evolution of these cohorts, have been epi cohorts, anonymous, you know, mega cohorts that are national biobanks. We'll still use those, and now our current biobanks. And there are some intrinsic challenges of using EHR data, which are a challenge to any epidemiological study, is kind of you're beholden to what has been phenotyped. And most biobanks will not be designed to do some systematic collection, particularly in subsets where there are probably, you know, very important features that you may need to get. Maybe at, you know, at UCLA, there may be very, you know, all the imaging may be exactly the same, and you'll have systematic ascertainment for those. The challenge is, at least for us, because we've tried to explore some of this, is that there is the cancer care in at least our health system happens both at MGH and then all at the cancer center and then at Dana-Farber. Brigham doesn't have one. And Dana-Farber is technically not within our health system. And so linking all the data between the two is not as straightforward. There are some cardio-onc focus folks in the lab who are starting to endeavor with that. Maybe it's, you know, the Bogdan Pasanuik and others at UCLA are working on this. And so, you know, maybe they have started looking at linking these data together, but, you know, I don't know. I mean, in other subs like in HIV, you find that even though HIV itself is a powerful predictor for cardiovascular disease, a polygenic risk score actually does stratify risk in that context. Because the cohorts are still pretty modest, it's mainly subclinical athero, but seems to suggest that it'll predict risk less well in the context outside of HIV. Similarly, actually for diabetics, score performs better in non-diabetics compared to diabetics. So again, like as the data gets larger, there's more profiling. We can start to understand where it's more helpful, where it's less helpful. So I don't know.
No, so yeah, thanks for that response. Because I think especially, I mean, I'm not talking about necessarily all the sort of lower incidence of rare malignancies, but I think if you're looking at the more survivable disease states like breast cancer and prostate cancer,
Yeah.
probably amongst the most relevant malignancies across every whole American, millions of survivors available. That probably would be a higher enough signal to look at what their sort of risk profile is on top of this.
Yeah, I mean, I think
Most
totally. No, I think there could be opportunities outside of coronary artery disease. Like there aren't great polygenic risk scores for heart failure, but there are pretty good ones for like LV mass and LV dimensions. You know, if there's an abnormality, could those individuals be more susceptible to, you know, what happens if the chemotherapies are great AFib polygenic risk scores? Totally untapped. So, Jeff.
Paradigm shifting work. And I think when you look at paradigm shifting work, I like to think of the potential unintended consequences of it. And if we're looking at this as being a tool to use, let's say earlier in life, and then let's say take the inverse of what your focus was here, where you have a low score, and how that may impact behavior, and whether or not someone in their 20s, 30s who's deemed to have a low score would think that, you know, I'm invincible. And with this being it's a static, you know, score, we're born with it. Is there the concern that that can lead to these unintended consequences, potentially of maybe, you know, things like this invincibility syndrome, I guess, but also on kind of related to that and how you would address that is, have you looked at patients who still developed coronary disease despite a low score, and like what are the features that characterize that group?
Okay, great question, Jeff. So Jeff is saying, when you report a polygenic risk score, we've been talking about individuals at high genetic risk. Could there be unintended consequences of communicating low genetic risk? Might people do things that are otherwise unhealthy? And for individuals who have low genetic risk and have events, what could be driving their risk? And these are good questions. I think a good parallel has been from legacy statin literature. People have talked about this licensing effect. If you give somebody a statin, are they likely to like eat whatever they want because now they think that they're on the right medicine to lower their cardiovascular disease risk? And maybe in the early days of statins, some of that notion was true, at least anecdotally among my patients. I don't think that actually happens, or at least nobody necessarily talks about that. Challenge, so the absence of clinical risk factors today, I don't think communicating that with clinical risk factors necessarily tells somebody that they should make their clinical risk factors more abnormal or do things. I think if anything, people just kind of keep doing the same thing that they do today. Down classifying risk based on a polygenic risk score, the evidence isn't as good. However, with these scores better discriminating risk, including at the tails, you do start to begin to identify individuals at lower and lower risk. However, as we know, there are many other acquired risk factors that influence risk powerfully. Like if they were still smokers, diabetics, those will overwhelm the low genetic risk. And so what we are all moving towards in the field are more of these integrated risk scores when we incorporate these things. So then you kind of dilute out the genetic contribution by saying, okay, there are also other risk factors. Like we should not be considering any of these in isolation if the end goal is predicting for coronary artery disease. So I think, reasonable considerations, and this is the importance of risk communication as well, right? Because we don't necessarily need to place untoward, emphasis on one risk factor relative towards the others. I think it's our goal to educate about all these things. And then also the dynamic nature of the importance of these risk factors. I mean, these are complicated concepts. They're complicated for clinicians, complicated for patients. And so we do a lot in thinking about what these reports should look like and how do you communicate these risks.
Pradeep, can you hear me?
Yes, sorry.
Okay. So I'm responding virtually from Los VA, Franny Modi. I know that the focus here has been with LDL cholesterol. Has there been any work looking at Lp(a), and would that make the PRS more powerful, especially in the South Asian population?
Yeah, this is a great comment. So is there an opportunity of a polygenic risk score in the context of Lp(a)? Now, Lp(a) is among the components in a polygenic risk score. So Lp(a) is an LDL-like particle associated with incident cardiovascular disease. Unlike the other lipoproteins, they're all heritable, but this is overwhelmingly determined based on genetics. About like 94% of the population-based variance is all explained by genetic variation, basically at one locus. And the gene is interesting. The LPA gene is just next to plasminogen, the gene for plasminogen, and arose as a gene duplication event based on plasminogen. So the protein is an additional protein that is on the ApoB-containing lipoprotein, but it has kringles and other features that are very much like plasminogen. So in addition to promoting atherosclerosis, may also promote thrombosis. And because it's so highly heritable, is a really nice opportunity for mechanistic inference and causal inference that suggests that it likely is a causal risk factor in their ongoing clinical trials. So, and so obviously, as precision medicine notion, if these trials bear out, you would allocate these medicines to individuals who have high Lp(a). Now, could there be a role for genetics on top of this? We have looked at this in the context of the genetic contributors of Lp(a). Like if somebody has high Lp(a), should you do a genetic test? Unsurprisingly, you're basically capturing the same information. Somebody has Lp(a) already, you're not learning anything more. You already know that it's largely genetically determined. As far as a prognostic tool, it's basically telling you the same information. And what about the non-LPA alleles that go into a polygenic risk score? To be honest, we don't know. The clinical trials that are event-driven clinical trials have not completed. The Novartis trial last year, maybe the year before, finished its enrollment. Amgen is starting their siRNA for Lp(a). So there could be an opportunity, but whether it just will stratify risk and upclassify risk or identify benefit, we don't know. It's helpful to know that there are other therapies where we've tried this, like in one of the CETP inhibitors, evacetrapib, raises HDL cholesterol, also doesn't really change LDL cholesterol. There's no interaction there. We don't identify individuals. The overall trial is null, but there wasn't like a signal among the people at high polygenic risk. So I don't know. I think at minimum should be a risk factor in that context, but I don't know if it'll identify particular benefit by the greater relative risk reduction.
Thank you.
All right, well, thanks again, Dr. Natarajan, for that wonderful talk. On behalf of everyone here, we really appreciate your time.
Great.
Thank
Yeah,
you.
thanks for having me.
Pradeep, as one of our first in-person back Grand Round speakers, might we get a quick photo?
Oh, yeah, of course. Thanks, everyone. Greg, good to see you. Carol, good to see you. Hope to see you guys soon.
We'll see you soon.
When-
Terrific job.
Oh, yeah.
Appreciate it.
when-